itself. We've been working on our networking within the community and also within the state. The State Health Day was held last week, and we were asked by the state Department of Health to highlight our lead program, which is highly coveted within the state. And Michaela, who's the lead coordinator of that program, was at the State House all day. And Matt Gosh went with her as part of our communications program. And they got a ton of traffic, and people were taking notes, trying to figure out how we do our process. And they were impressed that we had our handouts in both English and Spanish for people to receive. And that was a great day. And it also was a great showcase for St. Joe County. Our environmental health team went to St. Joe County Builders Breakfast last week and gave a presentation about their work in their unit. Our care unit went to an event last night held at the Century Center, sponsored by the State Department of Health. There were 40 tables there. It was a high traffic area, and our care team was there. A group of us made a presentation to the St. Joe Med Center Family Practice Residency and faculty last week, and that was very well attended and very well received. The residents were asking if they could do a rotation in the department. So I guess we didn't bore them too much, but that was a positive sign, I guess.
Yeah.
But we're actively speaking to our local and state legislators and trying to keep tabs on things that are going on downstate with HFI programming and other programming as well.
I'm curious, the program at the Century Center yesterday, what was the target audience? Was it healthcare practitioners? Was it like the community?
It was the community, actually. They had a lot of, they gave out immunizations as the Indiana State Immunization Coalition, but there were several tables, several local organizations that people could use for resources. And one of them was our care unit, who can do social needs assessments and talk to community members about needs and resources that are available to them.
How busy was it? Was it pretty well attended, or?
It was very well attended. I think they had, I want to say 400 people there last night. So for a school night, that's pretty good.
And are we having, it looks like we're having a special presentation on lead later.
We are, Michaela.
Yeah, is this the same presentation that she gave to the state, or is this kind of jury-rigged for us a little bit?
You can ask her, but I think it's similar to the presentation that we gave to the family practice residency.
So at the State House that we went to last week for Public Health Day, it wasn't necessarily a presentation. We were just had a table out where people would walk around the State House. There was, I believe, 15 health departments altogether that were asked to host a table. And we just talked about to passerbys about our lead program, how our process works, things like that. What I'm about to present on is I will talk about what our program looks like, but all the accomplishments and the data that goes along with that. So not necessarily the same, but I will go over more in depth about our program.
Thank you.
Mhm.
Do you have any questions about the numbers or reports that you received? I don't think there were any major revelations in the report.
A couple of questions. Anybody else want to start? On the new food ordinance code that we passed last month, how's that going with the council? Is it moving forward, or?
Carolyn, do you mind?
We haven't been commanded to present it yet. Amy is better, or Jen, to tell me how that meeting schedule goes? When do I go? At the end of the month? Meeting. So we're still waiting. It's not fully blessed yet.
Yeah, great, thank you.
Okay.
It's on the right tracks. The train is moving, but not at a fast pace.
But no issues with it.
No issues.
I just had a couple questions on the vital records, data. I was wondering if there's a error in the year-to-date 2024 occurrences. They're like half of the year-to-date 2025. I suspect there is.
Can you come to the microphone, Erica?
Page 30?
It's
Oh, yeah,
page 30.
There's a page.
I'm sorry, I can't get my internet up. Thank you. Okay, so this is actually, it's less than 100. Is that what you're commenting on for the year to date? Or are you saying the,
Year-to-date, if I'm reading this right, year-to-date 2025 occurrences, births, 626. Year-to-date 2024 occurrences, 324.
So it may have been the day that we reported, which is an actual conversation that I had with Doctor recently, because we may be changing dates of reporting. So I tried to wait until the very last day that our reports are due, because we have to report based on what the hospitals enter electronically into the state system. So if I have to report a date a week and a half later, that number is going to be significantly different than if I report it on the 15th versus the 7th. Just based on the input comes from whatever the hospitals put into the state system. And it may have just been a filing date. I'm not sure. I can double check those numbers tomorrow, and I can let you know.
Okay, well,
Yeah.
I mean,
But just looking at 24 and 25 and how the numbers for birth and death are both significantly different, I'm guessing it was just the day that it had to be reported was probably earlier.
okay.
Okay.
Also, what is a birth certificate? Is that assessment or
Assistance.
assist?
So we had budgeted to start assisting the public who showed a need for not being able to financially pay for a birth certificate. A lot of that goes through the CHWs and then other community partners. They take the Community Health Workers Assessment Survey. And if they can show evidence of a need, then the birth certificate is given to them with no cost.
Gotcha.
Yep.
Great.
And some of those are, for example, like teenagers who are getting their driver's license, they're 16 and they may not have the means to pay for the birth certificate.
All I have. Any other questions for Dr. Migliori?
I just had I forgot to ask you earlier, I had a couple of questions on the nursing page 29. And two are, well, there's one where, again, we have a name of a new hire, and I don't know if we want to keep that in there or not. But also public health nursing, it says, communicable disease cases in January. Should that be January or February? Okay, we're gonna get an answer. Oh, no, Ashley's, yeah.
That was just a typo.
That was
It
a
is
typo.
February, yes.
Okay, so that'll be changed before it goes on the website. Okay. And the other thing I was curious about is tuberculosis. If I'm, oh wait, no, the numbers are going up. Okay, never mind. I was wondering if there was a trend, but that was changing, but maybe not quite so much. But I guess if you have anything to say about how tuberculosis numbers are and how you're dealing with that situation?
Sure. We are seeing some more TB and some active cases that are not the normal cases. Like normally we think of tuberculosis as manifesting itself in the lungs, but we have patients that it can manifest in other body areas too, like the bladder, the bone. You know, they do an x-ray and they see an abnormal bone, they immediately think this is going to be bone cancer. And then when they do the biopsy, they find out that the person actually has active TB. So some of those are cases. If somebody tests positive on their QuantiFERON, the blood test for TB, the first step we do is get a chest x-ray. And if their titers are high in their blood, but their chest x-ray is normal, that's considered what's called latent TB, meaning that it's sitting dormant, but it can go active at any time. And active TB is when you can actually see it in the lungs or in a bone or in the bladder. So we've had historically difficulty getting patients with latent TB, those ones that are just sort of waiting to bloom potentially, into healthcare situations right away. We can get the medications for free from Purdue University. And that's a pretty quick turnaround time within a day, but we have a difficult time getting patients who are either uninsured or underinsured into a provider to get treatment for TB. And many providers do not feel comfortable treating TB because it's not something that they do on a regular basis. So we've come up with a program where I will actually see the latent TBs for their first visit and get them started on medications, because it takes a good 2 to 3 to 4 months to get into a clinic like Indiana Health Center or HealthLink, someplace that will take the patient. And so that way we're getting them started on treatment rather than waiting 3 or 4 months and hoping that it doesn't become active. So our TB numbers are up because we're actually seeing and starting treatment. So then the patient gets an appointment to follow up within a couple of months.
And if you're in every situation, for example, if you have a private provider, if it's you go to a separate doctor, you get tested, and the discovery that that person has TB comes from the person's doctor. Does the health department still, that's required to be reported to the health department?
It's
Correct.
reported, it's a state reported disease.
Okay.
And we are sort of on call. We don't directly manage them, but we can help that provider, sort of give them the recipe for that particular patient, because it depends on the patient's age, on their generalized health, what their chest x-ray looks like. And then there's a sort of recipe as to which combination of medications can be recommended. We can also help that patient by getting that medication free from Purdue for the patient, but then they would still be monitored by their provider, but we will help assist in that process, getting them the medication.
So the TB nurse, for example, might not be actively involved in monitoring the case, but you're aware of that case, and then you're also providing assistance to whoever the provider is as needed.
Giving them the resources to make it easy as possible. And she's awesome. She does an awesome job, and she's always up on the latest, and she has like a red phone to the state. If there's a resistant case, she gets the specialist on the phone, and she does a great job.
Especially if there are a lot of providers who don't see this every day.
Right. They
Having
don't
somebody
know.
who
Yeah.
knows this disease in and out is helpful.
And when we talk to different providers, we encourage them, we're here to help
Yeah.
you. You'll need to write the prescription, but we'll send it to Purdue. We'll help you through this process and get the patient treated.
Thanks.
So how do we build that for you then? You're actually doing patient care.
Well, they don't have any money or insurance usually, so we don't bill, but I do see them and they document it in a chart so that it's documented.
You
We
don't
ask,
have like a cash pay, like set price or need-based sliding scale.
no, it's something to think about.
Yeah.
No one has done it before me, so no one wanted to, it's a little bit, off the beaten path. Nobody wanted to do it, whereas I wanted to be able to get the patient started on the medications as soon as
And
possible.
then this is a question for Marcel. And also affects you, but
I have malpractice,
okay,
yeah,
that's what I was gonna ask.
Through the county.
yeah.
We-
Okay, so it covers direct care though,
Yes.
not just
Yes.
oversight.
No,
Okay,
yeah,
just
it covers
making sure.
direct care. I was very careful about that.
Well, and part of the reason why we're going to have an assistant director of finance to deal with billing is to
To try
hopefully
and
have
build
somebody
more for
who can-
services, yeah.
And but also to try to address those questions of where can we recover funds, recover
Revenue,
money,
yeah.
revenue, yes.
You really, and it's, I love that your concern is patient care. That's all of our concern. But I do think you could do some kind of sliding scale
Yeah.
billing. Like, I don't have, I'm a business owner, so I have crap insurance, but it's like, if I could come here and pay so much cash out of pocket, then I would come here.
Right.
So at least to start and, we don't, not that it's all about money, but I mean, we also want to show that we can do this and
Be
continue
responsible.
to do it.
right.
Yes, yeah.
Fiscally responsible.
Anyway,
Thank you. Any other questions or comments?
I do have a question. When you guys were talking about the community health workers doing needs assessment, for example, like the kids that need their birth certificate, do we do needs assessment just on, are we allowed to do it just on kids? Like, what can we offer kids as separate from their parents without getting in trouble about, going behind a parent's back? Not that you're doing that, giving them a birth certificate, but because kids have their own needs assessments that maybe their parents aren't meeting their needs. That sounds terrible, but you know what I mean?
Yep, absolutely. So, yeah, so our community health workers primarily work with adults when it comes to the needs assessments. Now, if there is a child that has a particular need and they're legally emancipated, that's one thing. Though we typically work through their parents or legal guardian in these circumstances to help meet the child's needs. So when it comes to documentation, when it comes to filling out the needs assessment, that's all typically under the parent's name. Now, if there's, unique situations when it comes to the one thing or the other, we might work in partnership with, for example, Youth Service Bureau or something along those lines in order to make sure that individuals' needs are met.
Like, because kids they don't have food at home. Like, and I'm thinking with our school program, that's why I asked, because is it something that the school liaisons can say, hey, if you need something, like, let us know. If you don't have clothes, if you don't have food, like that would involve a needs assessment, but I just didn't know what the legality of that was, doing it without, not involving a parent.
I would say that typically our services aren't, outreach isn't targeting children, like in schools and stuff like that. If we do outreach in schools, it's towards families. So we'll maybe send a flyer home with kids and they bring it to their parent and then the parent reaches out, or the school health liaison for one school district or another will say, hey, I've had a parent that's had an issue with this, or another thing. And then in which case we'll work with both the school health, the McKinney-Vento liaison or the parent directly in order to meet those child's needs. We don't interact with children one-on-one much directly like that, I would say, at all.
Like, we're not allowed to, basically. Is that
I-
something for the school liaison? I don't know. Maybe for
I
the
would
lawyer.
just say that's not something that the community health workers do.
Yeah.
We involve the parents when it's a minor, just
Yeah.
because of law.
And if there's
Okay.
ever a situation that our community health workers walk into where we see unsafe things, we follow the legal procedures of mandated reporting with Child Protective Services and anything else like that.
Okay.
Thank
Any
you.
questions?
Other questions, comments? All right, should we move to the spotlight or you?
I think we're ready for the spotlight.
Are you gonna move the slides for me, Jenny? Okay.
Look at me.
Oh, I think the other way.
How did I get all the way to the end?
Okay.
Good. Okay. Hi, everyone. I'm Michaela Enright. I'm the lead program coordinator here at the St. Joseph County Department of Health. So today I'll just be giving over a brief overview of our lead poisoning prevention program. So what exactly is lead? Lead is a naturally occurring toxic metal that competes with calcium and iron and other metals in the body, and it is also naturally found in the soil. Lead can also be found in other items as well, such as in paint in homes built before 1978, and pipes, cosmetics, toys, pottery from other countries, and among other items. It is estimated that about 80% of homes here in South Bend have lead in them, and about 70% of homes here in St. Joseph County have lead in them. So it is still quite prevalent here in our community. Lead is a neurotoxin that it can cause irreversible damage to the brain and to the nervous system. So it can cause things such as stunted growth and development, behavioral and learning issues, speech and hearing problems, things like that. In children ages 6 and under, they are most vulnerable to lead poisoning because during this time in their life, they're still growing and developing. And they also tend to exhibit hand to mouth behavior. So this can cause them to unintentionally ingest or inhale lead dust. And then lead can also be passed from a mother to her unborn baby during pregnancy. So this can cause things such as low birth weight or miscarriage. So taking this all into consideration, it's safe to say that lead is a major public health issue, especially here in our county. So it's important that we continue to address it. You can go ahead and go on to the next slide. So here is our multi-unit lead structure here at the health department. We have a very collaborative approach with lead. So we have 3 different units that work together on it. We have our nursing unit, our care unit, and our environmental health unit. In our nursing unit, we have our disease investigation specialist / lead coordinator, so my position. So I receive all of the elevated lead cases, excuse me, through the state, and then I will then assign and distribute those cases to the appropriate person. And then we have our public health nurses. So they complete case investigations for all lead results that are confirmed greater than 10. In our care unit, we have our community health workers. They complete case investigations for all lead results that are unconfirmed and then confirmed less than 10. And they also perform community outreach, which I'll get to here in a few minutes. And then in our environmental unit, we have our licensed lead risk assessors. They conduct free lead risk assessments in these following home environments: where children under the age of 7 live and visit frequently, where pregnant women reside, and where a lead poisoned child has already been identified. You can go on to the next slide. So before we go any further, I want to go into some case terminology regarding lead. So when we say a child is unconfirmed, this means that they have had 1 capillary finger stick test that is greater than or equal to 3.5, because lead is considered to be elevated at 3.5. And then a child is confirmed when they have had either 2 capillary finger stick tests that are done less than 12 weeks apart, where the level is greater than or equal to 3.5, or simply just a single venous draw that is greater than or equal to 3.5. And then a child is considered to be in case monitoring when they have a confirmed lead level of 3.5 to 4.9. And then a child is in case management when they have a confirmed lead level greater than or equal to 5. So that is when we are required by state law, when a child in case management, to actually go out to the home and do a home visit and a risk assessment. So that is when either our public health nurse or a community health worker, they will do a nutritional and development assessment for the child. And then our risk assessor would, of course, then do a risk assessment of the home to see what potential sources of lead exposure is happening there. You can go on to the next slide. So these are our accomplishments for 2024. So looking here at our new cases that we received comparing 2023 to 2024. In 2023, we had 272 new cases going to case monitoring / unconfirmed, 58 new cases in case management. So we had a total of 330 new case investigations in 2023. In 2024, we received 335 new cases in case monitoring / unconfirmed, 48 new cases in case management. So that gave us a total of 383 new case investigations for 2024. You can go on to the next slide. So looking now at our testing numbers for St. Joseph County, I know this is something that we all like to keep track of quite frequently because, of course, here at the Department of Health, we want to make sure that any child that is eligible to get tested for lead does get tested. So looking at 2023, there were 3,484 children tested for lead here in St. Joseph County, and that does comprise of children who were tested here through us internally at the health department for lead, and those that were also tested outside of us. So those that do get tested at doctor's offices and things like that. And then in 2024, there were 4,693 children tested for lead in St. Joe County, which is a pretty significant increase. So we are really proud of the progress that we were able to make in 2024, and we hope to continue to do that here in 2025. You can go on to the next slide.
Any idea or any thoughts on how you've made such great strides there?
So I think it was a couple of things, which I will kind of get into, but one of the things I think that really helped us was beginning our clinical provider outreach, which I'll actually get into in a couple of slides. And then our next slide too, looking over at our community health workers and going out to more events. So I'll kind of go out over there in a few minutes talking about that. Looking at our lead risk assessments, we are comparing 2023 to 2024 also. You can see that there's two different types of risk assessments listed on the screen. There's an elevated risk assessment and public requested. An elevated risk assessment is when we are required to go out to the home because the child is in case management. So we have to do a risk assessment because they have a pretty high lead level. And then a public requested risk assessment, that's when the parent requests us to come out to the home, whether they have a child that's age 6 or under, or if they're pregnant. They don't necessarily have to have one done. It's not required by law for us to do one, but they're asking us to do it anyway. So in 2023, there were 60 elevated risk assessments and 57 public requested, which gave us a total for 117 for 2023. And then in 2024, there were 59 elevated and 88 public requested. So that gave us a total of 147 for the year 2024. Next slide. So now looking at the lead events that I was just talking about briefly with our community health workers, like I had mentioned, they not only do those lead case investigations for us, they also perform a lot of our community outreach. So what they'll do is they'll partner with other community organizations that hold events throughout the year. So looking at things like health fairs, like the thing that happened yesterday at the Century Center. So they'll go out to those types of events. They will provide education to families. And depending on the type of event, if it's appropriate or not, they will also offer testing on site. So our community health workers, they are trained to do the capillary finger stick tests. So they can do those on site at the event. And then afterwards, we follow up with the family, tell them their lead level and what next steps are based on that. So, and then also along with that, they will also host lead events at other places such as daycares and preschools, because of course we want to get out into the community and test as many children as possible. So in 2023, we had 40 lead events, which resulted in 265 children tested for lead. And then in 2024, we had 76 events, which resulted in 377 kids tested for lead. So we really ramped up the number of events that we hosted or attended for 2024. And next slide. So our clinical provider outreach, as I just previously mentioned, this is something that we started doing in 2024, which is one of the reasons why I think that we were able to ramp up our testing numbers for the year. I don't know if you guys remember, we had hosted our first Lead Free by 3 conference back in March 2024 last year. So we invited local property owners and clinical providers to this conference, and we presented on clinical and environmental aspects of lead to them. So we talked about how do they test for lead, why it's important to test for lead, how to report those lead results, the case management requirements for children who do have an elevated lead level, and the risk assessment requirements and what that process looks like. We had a really great turnout from that conference. I believe, if I remember correctly, I think we had over 60 people attend. That's including clinical providers and property owners. And because we had such a great turnout with that, we wanted to continue that afterwards. So after our conference, we began reaching out to providers' offices individually to ask if we could speak with their healthcare providers and their staff members, so like their nurses, MAs, people like that, to speak with them about why lead poisoning is such a big problem here in our county, how they should be testing, why they should be testing, and how to report those lead results. So something that we started last year and we are going to continue to do here in 2025. Next slide. So lastly, these are our upcoming initiatives here for this year. We are planning to host another lead conference this year, but this time, instead of hosting property owners and clinical providers, we want to host daycares this time. And we plan to do that. We're still in the midst of planning of how that's going to go. So we are hoping to do that in the late spring / early summer. And then our environmental health unit, they are planning to do a soil sampling event at the Hurwitch Iron Site in collaboration with the Near West Side Neighborhood Organization. So they are doing this event in response to the recent ongoing demolition and cleanup that has happened at the Hurwitch Iron Site. So what they're looking to do is take soil samples of the properties nearby that site that have not been tested previously for lead. And I know that they're still in the process of getting that plan. So I believe they're trying to get that done sometime next month in April. And then National Lead Poisoning Prevention Week, which happens this year at the week of October 19th through the 25th. We plan on hosting events again this year for that. Last year in 2024 for National Lead Poisoning Prevention Week, we hosted really 2 successful events that happened. I believe one was at the Charles Black Center and the other one was at the Ron Roof Neighborhood Center. At those 2 events, we had over 300 people attend combined and over 30 kids tested for lead. And because of how successful that was, we plan on doing something similar again this year. And then, of course, we continue to do our clinical provider outreach and our lead testing events because we want to make sure that a lot of people here in the community are educated on lead, of course, and that we just want to get more kids tested and improve their health regarding lead poisoning. So, thank you, and I will take any questions if anyone has any.
So what does testing look like?
So are you talking about in terms of when we test or in the
Yeah.
provider test or kind of just in general?
So when you're going out to these events and you're testing,
Yes.
what do you do?
Yeah, so depending on the type of event we're at, so like if we're more so at a community event like we had yesterday with the Indian Immunization Coalition, to people who are, passersby, if they're in, we will talk to them about lead, see if they have a child that's under age 6. And if they're interested in testing for lead, they'll go ahead and get that done. What they do is the capillary finger stick test. So it's kind of like, when a diabetic tests for their blood sugar. It's very similar to that. They prick their finger and then we use the filter paper method. So it's these little tiny filter papers that have circles on it. You have to get the blood in those circles. And then we send that specimen out to a lab. And then of course we will receive those results and then contact and follow up with the parent after that once we receive them.
So your results are not instant. You have to actually send them out.
Yes, so the method that we use, we do not get them instantly. I know a lot of providers' offices will use the point of care testing system, which is where you do get those results instantly, but at least on our end, we tend to use the filter papers.
Okay.
And then if they do have an elevated level 3.5 or greater, we will then recommend for the parent to get the child tested with a venous draw within 3 months.
Is there a reason why you use the filter paper method? I mean, is it a cost reason or is it a
So-
convenience reason?
So
to Go out in the community?
Yeah. So I know we do, I believe we still have the point of care test system, right? I don't know if it's just something that community health workers prefer more rather than a point of care, Alyssa, or. Yeah, thank you.
So the point of care machine is very finicky. Imagine trying to draw blood from a squirming 2-year-old who's very, very upset and you have to fill a tube about this big and like 0.5 millimeter wide and there can be no bubbles
Oh, okay.
before it goes into the machine. So it's something that's difficult to do. And also, the most accurate results tend to come from the lab, especially since, the CHWs make sure to clean the finger as best they can, remove environmental contaminants and things like that. So we tend to find that one, it's much easier to do at events. And 2, we get very accurate results from the lab from using the paper filter method.
Thank you.
What was the turnaround time for that? Like-
So I believe it's within 4 to 7 business days, we typically get results back. And then we, of course, take the parents' information so we know how to contact them once those results come in.
And you are only testing children that are 6 years or younger?
Yes, correct.
Okay.
Yes.
What if somebody that was older wanted to test?
So what we typically tell them if they have a child that's 7 or older, we tell them that they should ask their primary care provider if they want to get tested because we typically just do 6 and under.
Can they call in and just come in for that test?
At our immunization clinics.
Yeah.
Yes, yep, at our South Bend and Mishawaka, we do the capillary, the same filter paper test as well in our clinics. And then the CHWs too, if let's say transportation is an issue, the parent can't for some reason come to an event or they can't come to the immunization clinic, we can have our CHWs also just go out to the parent's home and test them at the home as well, if that's a barrier.
And is there a cost, what's the cost? to have
So
done?
we will, if they don't have insurance, they don't have to pay for it. We count them as indigent. So we have a contract with LabCorp where we are able to do that. If they have Medicaid, it just gets billed from Medicaid, and I don't believe it typically costs the client anything. And then if they have private insurance, I think that just depends on, their policy and whatnot, but yeah.
So no sliding scale cash pay again? Okay, and then you said that for them to be eligible for testing, they have to be under 6 or pregnant? Is that?
So
You do
for the
pregnancy?
risk assessment, you can be a pregnant person can be living in the home and we can do a risk assessment. So we don't test pregnant women for lead typically, or at all, actually, I'm sorry. I think what Nancy does, the prenatal lead program coordinator, I think she gets in contact with their primary care provider or their OBGYN, I'm assuming. And if based on the risks that they may have, like if they live in a home older than 1978, she may tell them, hey, she might be at risk for having lead poisoning because she lives in an older home. So she'll try to coordinate that with her provider.
Or if they grew up in a home, is that what you mean? If they grew up in a home that was older? which
Yeah,
is
so like if
most-
the woman's like currently pregnant, living in a home that was built before 1978, we can do a risk assessment. And then if it deemed necessary, if they believe that she's at risk for currently like having lead poisoning, that she's currently being exposed to it, she will speak with their provider.
So
about
if
that.
somebody grew up in a home though, meaning just age wise, that they were before then, doesn't lead stick around? Like it's still in their system? The
So,
mom?
yeah. Yeah, so lead does take a while for it to be removed from their system. So but if they're currently living in that home, then yeah, we can do that risk assessment and then see if their doctor recommends
But
them
not
getting
like
a blood draw.
functional medicine, historical,
No.
you know, I'm going back to the root cause
Yeah,
stuff, but
no.
okay.
And the reason why we focus on, because you're probably thinking, why do you stop at 6? What, don't you care about anybody else? But the reason is the lead is more harmful to a developing baby in utero or to children under 6, whether they're still developing, they're smaller. And so they don't tolerate the lead levels that you do as in a bigger body and as an adult. So we're really worried about those tiny humans that they're really going to potentially take a hit on learning disabilities, seizure disorders, neurologic problems that they develop because of lead poisoning.
Yeah, it's risk prioritization
Right.
of
Those are
our
the ones
limited
that are at
resources
risk.
to people who are at most at risk.
Yeah.
Yeah.
So if there is someone that is 6 or younger that,
Mhm.
that does have lead, do you follow up, like especially with the rest of the family? Because it could be something in the home.
Right, yeah. So if there are other children living in the home as well, where we identify a child that has an elevated lead level, we will recommend for them to get tested as well.
And do you guys keep track? I mean, do you guys keep track of that or?
So if
really-
it
you're
comes,
just
if it
really
does,
focusing On the 6-year-old?
yeah, so if it does come back elevated, of course, we would receive that result.
Okay.
But if necessarily, if, you know, if we're following up on a child that does have an elevated lead level, of course, we're going to follow up every 3 months or sooner based on when they need that repeat test done. But we don't necessarily, I guess, go back and say, hey, did you get your other child tested? We don't necessarily
Yeah.
do that, but we follow up once they do get that elevated lead level.
So what is the repeat test? Like how much later do you do the repeat test?
Yeah, so typically it's within 3 months. If they have a lead level that's higher than 10, I think that's when it starts to go to like 2 months, 1 month. And if you start to get into like the 20s and 30s and 40s, that's when it becomes even more frequently because we want to make sure that it's decreasing.
Okay. Thank you.
Yep, you're welcome.
My question is, on the lead risk assessments that are requested by the public.
Yes.
Are there any limits that you place on what type of house they have to have or a family structure in order to, like, for example, if it's only, 2 senior citizens and they want a lead risk assessment, will you still go out and do that? Or do you just say only if you have a child under 6 or a pregnant woman in the home?
Right, yeah. So like you said, there has to be a pregnant woman residing in the home
Okay.
or have a child that's age 6 or under. But let's say, like you were saying, it's like a grandparent's home, for instance, and let's say their grandchild comes over more than 6 hours of a week, then they are eligible to get a risk assessment done as well. They don't necessarily have to live there, but they have to spend over 6 hours a week in that residence for it to be checked.
Okay, so we're again, risk,
Yes.
prioritizing
Right. 'Cause,
resources.
like if the grandparents, they don't have any, let's say that their children don't come over that frequently. But if they live in a home older than 70, then I don't believe we would do a risk assessment.
Would you do a risk assessment for like a landlord who maybe rents out older homes? I mean, or or would it be like, maybe it'd be because he's considering renting to a tenant who has young children, for example? Does it still have to kind of have some sort of attachment?
Breezy. I'm making the pregnant girl get it.
So we, by case, will kind of assess if a need
Okay.
is there. So in general, like Michaela said, it's typically only done if there are children actively living in the home or a pregnant person is actively living in the home. But there are times, like let's say during the winter months, we're a little bit slower. And if we have the capacity and a landlord calls in and says, I have a family who is thinking about this house, or I'm in between 3 families for this house, can you come test? we're more than happy to do that. We certainly want to be proactive and preventative, so we definitely will do that as we can. It is a little tougher, like when it comes August and we're just swamped with cases, we kind of, like you said, do like on a needs basis.
Okay.
And when you're checking, when you have a pregnant person actually call for an assessment, if there is elevated risk of lead, because we're not checking the pregnant ladies, what exactly do we do with that information then? What do we do for them? A
You mean
pregnant
if we
person,
find lead in the home, what do we do next?
right?
So I will say that for every risk assessment that is conducted, they receive lengthy education on how to best mitigate their exposure to that lead that's found in the home. Whatever is found to be positive comes with about 4 or 5 different remediation options. So they're given choices, and those will span from as simple as, covering chipping paint with packing tape, because not every family has the means to like completely replace a window or, do these full renovations, but it'll span from something as simple and as cost effective as that to replacing a window or repainting or whatever they need to do. So they're provided with different options and our recommendations on what to do. If they fall within City of South Bend limits, they're also pointed towards the City of South Bend's lead grant, which can offer money to help them pay for that remediation. If they don't fall within City of South Bend limits, they're pointed to the state's lead grant, which can also help them as well. And then if they're involved with our perinatal lead program, they can be pointed towards resources in the community that can help them. But yeah, typically from an environmental standpoint, we just provide them with a lot of education on how to mitigate that exposure.
And then do you refer them to someone for testing for the mom?
Yeah, so again, a lot of times you just point them to their primary care provider. A lot of places won't just do testing for lead for anyone 7 and older. And I think that's just from years of CDC kind of focusing on 6 and under. That's kind of been the guidelines for most medical practices. So typically they have to go to their primary care provider.
And if they don't have one, what? Okay, so I was like,
Yeah.
okay.
Yeah.
Got it. Because if we're trying to protect unborn brains,
Oh,
we
yeah.
need to know, okay, now what?
Yeah.
Yep, you got high lead. Sorry about your luck, you
Yeah.
know.
There are
Okay.
also other things like vitamin C. They give all kinds of practical advice.
Did I hear you correctly when you said that you test the home?
Yes.
What does that look like?
So we have an XRF machine that uses a laser essentially to read through layers of paint. It reads through several layers of paint. A risk assessment is just assessing for risks essentially. So we're not going to test every single surface in the home, but we're looking for areas that could be hazardous to the family, and hazardous would be chipping, flaking, cracking, little nicks in the doorway, stuff like that. So we will test that with the XRF. The XRF will let you know immediately if there's any paint identified that's positive or negative for lead. So we start with that, and then we test the dust to see if where it's chipping and flaking, is it creating excessive dust that is then ingestible for children. We can also test their soil. Soil's a big one in South Bend in particular. And then we can test their water as well, but we don't typically find that water comes positive.
Do you charge for that?
We do not.
And who can get this? So what if I wanted my house tested for lead? Could I-
So, yeah, so that would again be for pregnant women, if
Okay.
there's children living in the home or children frequently visiting. So like Michaela said, a lot of times somebody will call in and they'll say, my house was built in 1924. My grandchild spends the night every Friday, Saturday night. I'm just concerned. And so we'll go out and test it for them.
Okay,
Mhm.
thank you.
Thank you. Any other questions?
Yes, I have one other question. When you talk about lead in the soil, I'm assuming that it's from. I'm assuming that the high lead is from chipping paint from the outside of the house. Things are deteriorating. Is lead that might naturally occur in the soil, at least around here, really ever getting to concentrations where it could be particularly worrisome?
So it's hard to say. When it comes to finding lead in the soil, it's really tricky to pinpoint the exact cause.
Okay.
Especially like, I will say some of the neighborhoods that we visit more frequently by like Riley High School or if you're going towards the airport off of Lincoln Way, those are neighborhoods we frequent quite a bit. And in those neighborhoods, the houses are pretty close together. And so I would attribute the high levels of lead in the soil to the fact that you have so much construction that's taken place over time and so much chipping of exterior paint into the soil. But it could also be from years of leaded gasoline. It could be that that house next door was demolished 10 years ago and lead safe work practices weren't being used. So typically I would more often than not attribute it to man-made reasons that there's lead in the soil.
It's
than
not like
natural reasons.
radon. It's not like.
Right,
Okay.
right.
That's-
Yeah,
But it
yes,
certainly,
that's
it
part of what I
certainly
was wondering
does
about.
occur naturally, but I would
Mhm.
say for our area, it's more man-made.
Thanks.
Thank you. Any other questions? Comments?
Thank you for answering.
They're
so many
also
questions.
particular about where they get the soil sample. So
Mhm.
if, you know, until 72, 74, lead was in our gasoline. And so you wouldn't want to test right near a curb because even potentially lead from that exhaust from those cars would be maybe concentrated in right next to the curb. So they're very particular about where they do their soil samples to make sure that, you know, it's an area where people live and congregate.
Do you have to send that off or is that done through that machine? Where'd she go? You
The
can
the
just-
soil samples?
Yeah,
So you guys send them off to a lab. Yep.
okay, thanks.
All right. Thank you,
Right.
Michaela.
Thank you so
Very
much.
nice work.
Thank you.
You and your team. So yes, at this point, at this time, I'd like to, or I'd go ahead and entertain a motion to approve the health officer's report.
I will so move. Second.
Motion and second. Any further discussion or questions? Hearing none, all those in favor, please say aye.
Aye.
Opposed, say nay. Motion carries. Next item is new business. We have no new business. We have no grant requests. We have no old business. We're on to public comment. Do we have anybody signed up? Looks like we do, so I have to read this. At regular meetings, the public is invited to address the board for 3 minutes regarding items posted or not posted on the agenda. Individuals may only speak once during this section of the agenda. Speakers shall properly identify themselves by stating their name and address for the record. Personnel issues are not to be addressed during the open session of the Board of Health. The board president may interrupt, warn, or terminate a person's statement if the statement becomes personally directed, abusive, obscene, or inflammatory. Jenny, do you have any-
Cynthia Heckman Davis.
Welcome. Haven't seen you in a while. Nice to see you.
Good, thank you. Good afternoon. Cynthia Heckman Davis, MD. My address is on the sign-in sheet. President Lynn, at the last meeting, you requested we contact our legislators about supporting the Health First Indiana law. That part of the budget bill, I actually did that.
Thank you.
I also watched what I could of the Senate Appropriations Committee meeting last week, and I'd like to give a little summary of that. Senator Charbonneau was terrific. I have sent him a thank you email. I think that the budget bill in general won't be passed before the April state financial forecast is in, so I think we've got some time left. But the current earmark is about 1/3 less. It's going down from, well, $100 million each year for the next 2 years. It's what they're currently looking at. At the Appropriations Committee, State Health Commissioner Dr. Lindsay Weaver talked about the return on investment for public health dollars, which can be up to $14.30 for every $1 that we spend. The IU Richard Fairbanks School of Public Health evaluated 3 metrics of the many that our health department does. They looked at blood pressure screenings, maternal infant care, and fall prevention. This research is still preliminary, but even fall prevention programs are saving healthcare money. They're saving our state money. Before the Health First Indiana, only 39% of counties had a program to improve infant and maternal outcomes. And now 84% of counties do. Dr. Weaver was thinking by the end of this year, probably 100% of counties will have a program in place to help reduce infant and maternal mortality and outcomes that are bad. Resistance to the Health First Indiana law is coming partly from our own Senator Ryan Mishler, who said he had gotten pressure from his communities to cut or eliminate the program due to questions about the money's uses. I kind of got the idea that he thinks that our Department of Healthcare workers are going out golfing on state money or something. Mishler said that one county was providing services to undocumented people. Well, if that involved testing immigrants for tuberculosis, then that would be for everybody's safety and a very appropriate use of state money. Senator Liz Brown of Fort Wayne said, when HFI was proposed to us, we were going to see more immediate results, and these are all promises, and we're not seeing significant results yet, and yet we're doubling down. She floated the idea of maybe no longer inspecting tattoo parlors or maybe no longer doing lead mitigation. But nobody that I know of has promised immediate results. Public health takes time. It is clear that our legislators don't know a lot about how public health works. Our Department of Health is doing a lot of great presentations. I'm wondering if you as the Board of Health could request that some of the videos already present on the Department of Health website be shown maybe at Board of Commissioners meetings. County council meetings are just way too long already, but Board of Commissioner meetings as a way to educate our local legislators. And there are some good videos already on the site, and maybe after the session is done, maybe invite our local state legislators to an educational event about what our health department actually does. Thank you.
Thank you. Appreciate that very much.
Vicki Brown?
Good evening, Vicki Brown, and the pen ran out, so I'll get your fresh address on that. Vicki Brown with Dustin's Place. This is my first time ever coming here in front of some of you, but you may have seen me around the community. I wanted to come this evening and let you know about what we are doing at Dustin's Place now that we are so active and involved up here in St. Joseph County. Dustin's Place is a children's grief center providing no-cost grief support to children ages 4 to 18, as well as adults after the death of a person in their life. We do this in a peer-to-peer grief support model based off of the Dougie Center out in Portland, Oregon. I am the co-founder of that. My husband, Dustin, died on August 2nd of 2016 in a single car accident at the age of 34 years old. When he died, we had 3 very young children, a 6-year-old, a 5-year-old, and an 11-month-old child. He was a social worker. I was a teacher, and I knew I needed to get my children help through the death of their father, but I had no idea how to do so. Through my own personal grief journey and that of searching for help for my children, I realized there was nowhere to take them. I had plenty of options as an adult. However, I could not get them into anywhere. I was able to bring them for childcare while I went to my own grief help, but no one was seeing children. What we know is that 1 in every 10 children in the state of Indiana will experience the death of a parent or a sibling before they turn 18. That's 156,000 children in our state grieving a parent or a sibling. We don't have stats for that of classmates, teachers, neighbors, grandparents, only parents and siblings. So that's 2 to 3 kids in every classroom, making it the most prevalent adverse childhood experience in our state. And yet, Dustin's Place is only the 4th children's grief center for the entire state of Indiana. Our physical location is in Plymouth, Indiana. However, we serve St. Joseph County, being one of only 4, with approximately 51% of our families coming from St. Joe County to our physical location in Plymouth, as well as serving 11 South Bend public schools every single week in our peer-to-peer grief support model, meaning that we go into the schools for an hour each week for an 8-week curriculum, bringing together a group of peers, walking through similar losses and giving them a safe space to process that. What we know about childhood bereavement is that through proper supports, we are able to teach healthy coping skills, preventing unhealthy coping skills, turning to substance use to mask that death, turning to violence, incarceration rates of those who haven't received support at the time when they needed it. So we have worked really hard to remove barriers. We have no wait list. We do not charge for our services, and we come up into the community when needed. In Marshall County, we do also have a suicide loss team where we go out with our first responders on scene to support all families after the death of, after a suicide death, recognizing that acute grief care is crucial for those families. We also have in St. Joe County and Marshall County, our crisis team. This crisis team is available for schools, businesses, and organizations after the death of a person within their organization. We come out within the first 24 hours and we stay for as long as that school. For instance, that's our most popular need. A school has a student or a faculty member die, they call us in. We provide that acute grief support for students, faculty, staff, in that immediate aftermath. We work alongside community mental health agencies such as Oaklawn and Bowen, but with us being trained in children's grief, those areas we tend to take the lead on those so that we can make sure that the care provided is grief-informed care. So I wanted to come tonight and let you know all that is going on because I haven't had that opportunity to do that. And also because I know that mental health, especially mental health of children within your county, is a hot topic right now. And just look at how we can partner in the future. I know you have grants coming up available, that type of situation, but also awareness is huge, letting people know that we exist so that families who need our services can receive them.
Thank you. Very good. Thank you very much. Anybody else on the list, Jenny?
That's
Thank you. All right, next item on the agenda, time and place of next regular meeting, April 16th, 2025, 4:30 right here in fourth floor chambers. Before you leave, don't forget to take off your microphone. Take it home. And we are adjourned.
Thank you.
Thanks.